Even for most seasoned clinicians, ECG interpretation is a blend of pattern recognition and rigorous systematic analysis. Errors usually occur when we rely too heavily on the former and skip the latter. Here are 5 of the most common and clinically significant pitfalls in ECG interpretation. The most frequent error isn't clinical, it's technical. Reversing the limb leads is a classic trap. Swapping the right arm and left arm leads. This produces a T-wave inversion in lead 1 and an upright P-wave in AVR, which can be mistaken for dextrocardia or a lateral myocardial infarction. Always check lead 1 and AVR first. If lead 1 is entirely upside down, that is P, QRS and T waves are all negative and AVR is positive, suspect lead reversal before pathology. The two can be differentiated by looking at the chest leads. There will be no sign of dextrocardia in chest leads. Lead 1 shows inverted P waves, which in the absence of features of dextrocardia in the chest leads, that is, regression of amplitude of QRS complexes as you move from V1 to V6, should make one suspect lead reversal. But this is not the common right arm, left arm lead reversal pattern when you look at the inferior leads. At one look, the inferior leads make you think of an evolved inferior wall myocardial infarction. But the clue is the inverted P waves in inferior leads. Uniform negativity of the QRS complex and T waves along with P waves make one suspect a misplaced left leg electrode. When the left leg electrode is placed on the right arm and vice versa, the P wave, QRS and T waves, which usually have downward vectors, get inverted. In fact, such an ECG is usually misdiagnosed as inferior wall infarction unless one is careful to go in a sequential manner starting from the P wave, as is usually taught in ECG lessons. Distinguishing between a true ST segment elevation and mimics like early repolarization is a high-stakes challenge. Measuring the ST segment elevation too late in the segment or failing to identify the J point, the junction where the QRS complex ends and the ST segment begins. Overdiagnosing STEMI in patients with benign early repolarization syndrome, which is common in young healthy individuals, or underdiagnosing a subtle STEMI because the elevation isn't massive. Use the TP segment, the baseline between T wave and the next P wave, as your reference point for 0 and not the PR segment. Focusing only on the leads showing ST elevation can lead to missing the bigger picture. Seeing ST elevation in lead 3 and assuming it's a localized issue without looking for ST depression in AVL. Reciprocal ST depression is often the earliest sign of an evolving myocardial infarction. If you see elevation in inferior leads 2-3 AVF but don't see depression in AVL, you should be highly suspicious of pericarditis rather than a STEMI. True STEMIs almost always have a reciprocal reflection in the opposite leads. Medical school often emphasizes the S1Q3T3 pattern for pulmonary embolism, but in practice, it is neither sensitive nor specific. Relying on the absence of S1Q3T3 to rule out pulmonary embolism is going to be catastrophic. Missing a pulmonary embolism because the ECG looks normal or only sinus tachycardia, which is actually the most common finding in pulmonary embolism. Look for signs of right ventricular strain such as T-wave inversions in the right precordial leads V1 to V4 and lead 3, which are far more indicative of a significant pulmonary embolism than the classic S1Q3T3. Confusing between SVT with aberrancy and VT is a classic danger zone in the emergency department. Assuming a wide complex tachycardia is supraventricular tachycardia with a bundle branch block aberrancy because the patient is young or looks stable. Treating ventricular tachycardia with calcium channel blockers like verapamil, which can cause cardiovascular collapse in VT. But there is an exception, that is Belhassen's VT is a VT in which you have response to verapamil. Any wide complex tachycardia is ventricular tachycardia until proven otherwise. If in doubt, treat it as VT. Always compare the current ECG with the previous tracing. A borderline finding that hasn't changed in 5 years is rarely an acute emergency.